going to be recording for you the ABG content. I'm not going to put my face up because I just have been traveling, got back from Atlanta, and I look like I've been through the time zone. I am going to be posting your acid base and going over this thoroughly. I also want to encourage you to do your reading chapter 6 in your Corbett lab book. Please note for test purposes, I know your book says 1 lab value for norms. Osborne says another in your med-surg book. But for test purposes, we are going to go by the ones that are printed in the PowerPoint. The ones that are printed in the PowerPoint. So the normal pH will be 7.35 to 7.45 for test purposes. The normal CO2 will be 35 to 45. And the normal bicarb will be 22 to 26. Because everywhere you look, these are a little bit different, but that is the general consensus. I think it's crazy we do that to ourselves in nursing. I think that we should have universal norms and lab values, but I'm not over that. Okay, so let's get started with the PowerPoint. We're going to be doing acid-base, and I really want each of you to understand how to interpret ABGs. And when you should suspect what type of imbalance, there we are, clinical reasoning, as well as the treatment of each imbalance. That means right off the bat, a person comes in with COPD, you're thinking respiratory acidosis. I got to be watching for these signs. I've got to be making sure that I'm doing this, this, and this. After reviewing this PowerPoint, reading the chapters and articles, and I do have a really good article I want you to read, as well as some handouts. I will tell you the chapter in Osborne is rough reading. It's really hard and difficult for me to understand. So if you would concentrate mainly on this PowerPoint, and then if you want to go back and read chapter 6 as a reference in your Corbett lab book for further understanding of something you didn't understand, then I would encourage that. But I'm telling you, it's kind of difficult understanding Osborne. All right, when you finish this material, if you feel like you're still not getting it, something doesn't click, I want you to set up an appointment with me and us to discuss this before you take the test. Very important information, and I don't want you to mess up here by not doing well. Reading assignment, Osborne, pages 363 through 375. Article, Turning ABGs into Child's Play, lab book, Corbett, chapter 6, and then handouts I have posted. I've also posted some brain teasers as well as an interactive website to help you with this content. Lecture and discussion. We're going to be doing PowerPoint slides, Ms. Candler's Believe It or Not, critical thinking activities via websites that I've posted, and again, the brain teasers that I've posted. So once you've completed all the information, I want you to go back and do these brain teasers. Send me your answers, and I will send you the answers back to make sure that you are getting the content. They make you think a little bit. So we're going to start out doing Ms. Candler's Believe It or Not. So if you're at home, as I read a statement, and get you a little paper and pencil so that you should have this downloaded already, your PowerPoint, so that you can make some little marks. If you believe the statement I say, then I want you to stand up. If you don't believe the statement I say, I want you to stay seated, and if you're not sure, go halfway. All right, well, this exercise will give you some activity anyways. Your family might think you're a little nuts getting up and down, so you might want to do this in private. All right, here we go. Number 1, statement number 1. Normal pulmonary function requires a balanced relationship among respiratory, cardiovascular, nervous, and renal systems. Normal pulmonary function requires a balanced relationship among the respiratory, cardiovascular, nervous, and renal systems. This statement was true. You should be standing up. Number 2, carbonic acid concentration is maintained by the kidneys. Carbonic acid concentration is maintained by the kidneys. That is false. You should be seated, and that is because it is maintained by the lungs, not the kidneys. Bicarb is maintained by the kidneys. Number 3, Normal pH is 7.35 to 7.45. And if you were listening in the opening of what I said we would go by for normal values for this exam, you should not be missing this one. In fact, you should be standing tall, because it is true. Number 4, normal PaCO2 is 35 to 45. Again, if you were listening in the opening, you should be standing. This is true. Normal bicarb is 20 to 30 milliequivalents per liter. Normal bicarb is 20 to 30 milliequivalents per liter. This is false. You should be seated. I said for exam purposes, it would be 22 to 26. Number 6. When the kidneys fail, the resulting imbalance is metabolic. When the kidneys fail, the resulting imbalance is metabolic. The answer is true. You should be standing. Number 7. The carbonic acid bicarbonate buffer system is the major buffer system of the body. And that answer is true. You should be standing. Number 8. If the pH drops below 7 or rises above 8, death usually occurs. And the answer is true. You should be standing. Number 9. The PaO2 only indicates how well a patient is obtaining oxygen and does not indicate the acid-base status. The O2 level only indicates how well a patient is obtaining oxygen and does not indicate the actual acid-base status. Answer is true, should be standing. We only go by 3 things to figure out if someone has an acid-base imbalance: pH, CO2, and bicarb. The major effect of alkalosis on the central nervous system is depression. The answer to that one is false. You should be seated. The major effect of alkalosis on the central nervous system is excitability. The major effect of acidosis on the central nervous system would be depression. All right, so I hope you got a lot of those right. The measurement of blood gases is considered one of the most useful diagnostic tests when a child or an adult is in respiratory distress or impending cardiopulmonary failure. So it's very, very important that you understand the basis of ABGs. In your book, as far as in your Corbett book, lab book, page 128, goes over the purpose of blood gases and then how to draw blood gases, in general, how to collect samples and prepare the patient. So you need to read over that. But considering ahead, let's look at what is your role as an RN in dealing with patients who have acid-base imbalances. Number 1, recognize situations that are likely to cause acid-base imbalances. Remember clinical reasoning. Help to prevent imbalances from occurring. Clinical reasoning. Carry out orders and monitor the patient's response. Clinical reasoning. Knowing the signs and symptoms of acid-base imbalances. Basic nursing care and standards. So the nurse has a lot to deal with when you're taking care of a patient or a potential patient who may come in with acid-base imbalances. They did a study and they showed that they went in and looked at 110 random admissions at a hospital. And it revealed that those 110 random admissions, they did not look at their diagnosis. 56% of those patients suffered from some type of acid-base imbalance on top of the original admitting condition or disease process. So just because they're admitted with, respiratory failure or CHF or something like that does not mean that they will not or do not have an acid-base imbalance. Systems affecting acid base. The primary function of the respiratory system is to supply oxygen to the body cells and to remove carbon dioxide from the cells. Normal pulmonary function requires a balanced relationship among the respiratory, the cardiovascular, the nervous, and the renal systems. All 4 have to be intact and working properly. So when we look at the nervous system, the brain sends out and receives stimulus to maintain that balance. So the brain has to be intact, and it has to be intact because it's got to send the stimulus. So the nervous system has to be intact to send it to the brain. We know the medulla and the pons are the major brain centers affecting respirations. The medulla is the center for spontaneous respirations. So it's very important it's able to send signals to the brain. The cardiovascular system is important. We know it pumps oxygenated blood. That oxygenated blood goes through the circulation and through the arterial circulation and primary carrier of your red blood cells. As oxygenated blood is given to the tissues and the cells, we know unoxygenated blood containing CO2 returns to the heart and lungs via the venous circulation. So where it is oxygenated and sent back out again. Renal system. The acid-base balance of the body is particularly regulated by the kidneys to maintain homeostasis or balance through selective filtration and reabsorption. So this is very, very important, the renal system. So you got to get this. You got to get this. You got to get this. Acid-base balance is mainly regulated by blank and blank systems. Respiratory and renal. Respiratory and renal. But, as we just discussed, you have to have an intact cardiovascular and nervous system as well. Carbonic acid concentration is mainly maintained by the lungs. Carbonic acid, lungs. Carbonic acid, lungs. Think respiratory. As soon as you see carbonic acid, which we measure in the form of CO2, you think lungs, respiratory, acid. CO2, lungs, respiratory, acid. When you see CO2, what are you going to think? Lungs, respiratory, acid. Bicarbonate, HCO3, is maintained by the kidneys. Think metabolic. When you see bicarb, HCO3, what are you going to think? Kidneys, metabolic, base. Kidneys, metabolic, base. Kidneys, metabolic, base. Carbonic acid, you should have thought of what? Lungs, respiratory, acid component. Bicarb, should have thought of kidneys, metabolic, base component. So metabolic and respiratory processes have to work together to keep hydrogen ion levels normal and stable, and that's what it's all about. We're not doing hokey pokey, but it is what it's all about. All right, arterial blood gas analysis. ABG analysis provide important information about arterial oxygenation, acid-base balance, and alveolar ventilation. Long before outward signs of changes and vital signs occur, your oxygen, carbon dioxide, and pH and blood levels will become abnormal. Yes, the oxygen does not signify acid-base imbalance, but it tells you you're getting in trouble and that you're not compensating. So early changes in vital signs would be compensatory, increased heart rate, increased respiratory rate, normal blood pressure. As those start changing, then you start decompensating. So those were the early changes. Remember, clinical reasoning. I have someone in with a acid-base imbalance. What is the early changes in vital signs I'm looking for? Increased heart rate, increased respiratory rate, normal blood pressure. Then if you start seeing other signs and symptoms, then you know that they may be starting to decompensate. Blood gas measurements are the prime indicators of a patient's changing state. They reflect lung function, lung adequacy, kidney function, kidney adequacy, and kidney perfusion. So we can tell a whole lot by looking at the ABGs, particularly our two main systems, which we said earlier were respiratory and renal. The blood for ABG analysis is usually obtained from where? Radial, brachial, and or femoral. Radial, brachial, and or femoral, with your radial being the most common. Now, if you have someone that's in the unit, which we'll be doing critical care this summer, and they have an ART line, then you can draw blood from that. And there are some protocols that you have to do to be able to do that. If you are getting it in the radial, brachial, or femoral arteries, particularly the radial or brachial, you need to apply pressure for 5 minutes, full 5 minutes after obtaining your sample. And if it's in the femoral area, a full 10 minutes after obtaining your sample. So, do we know, or do we do this, or what is this? What is the Allen test? Well, the Allen test, and what we will do is a modified Allen test. It's used to assess circulation. It's used to assess circulation. It can also it's very important to do in that this test assesses actually for collateral circulation. And failure to do an Allen test prior to ABGs could result in severe ischemic injury to the patient's hand if damage to the radial artery occurs with arterial pressure. So you can actually cause damage if you've not assessed for collateral circulation before you do an ABG. Most of the time you will see your respiratory therapist performing this, and you will see them performing a modified Allen test. So how is this done? You will need to do this with me and write this down. Number 1, close your hand into a fist. You need to do this. Close your hand into a fist. Occlude the radial and the ulnar arteries on your hand that is in the fist. Do this now. Ask the patient to open their hand. Open your hand. It should be very blanched because of the lack of blood. Now open your hand, and it should be blanched. Now release the radial pressure, just the radial side, and the color should return within 10 or so seconds, okay? If it's taking a lot longer than that, then they may have some circulation issues. Repeat these steps. Close your fist, occlude the radial ulnar, open your hand, release this time the ulnar pressure. Once you release the ulnar pressure on the artery, again, should return in around 10 seconds. If it's taking a lot longer than this, I would not use that place because they may end up with some ischemic injury to that area. All right, so there's 5 steps to it. Number 1, close their hand into a fist. Number 2, occlude the radial and ulnar arteries on the hand that's in a fist. Number 3, ask them to open their hand. Number 4, release one side and check to make sure that it comes back within 10 seconds or so. And then number 5, repeat the steps except for the release the other side. All right, again, this is used to assess for collateral circulation. If you have any questions, let me know. Measurement of oxygenation. Both the PaO2 and the SaO2 are used to determine the adequacy of arterial blood oxygenation. Your Corbett book does an excellent job of explaining the difference between these and the terminology. The PaO2 measures the amount of oxygen carried in the blood, and the SO2 measures the oxygen hemoglobin saturation. The major purpose of evaluating the PaO2 is to determine the efficiency of ventilation, how well gas exchange is occurring. That's why we look at the O2 levels. Normal O2 is 80 to 100. Normal SaO2, which is saturation, is 95% or greater. If the PaO2 only indicates how well a patient is attaining oxygen and does not indicate the acid-base status, we've already talked about that. Now, this is for a normal, healthy individual who's under 60 and who's breathing room air, okay? So you will need to know these norms for exam purposes, particularly the normal O2, or oxygen level, is 80 to 100, and the oxygen saturation, or pulse ox reading, should be 95% or greater, okay? This PowerPoint's also trying to tell you that you don't have to look at the oxygen level to determine acid-base status. When are decreased oxygen levels expected? High altitudes, older individuals, those with COPD, all the above, and it's all the above. A patient with chronic respiratory problems may actually have a low PaO2 level and still be adequately oxygenated because of compensatory mechanisms. A patient who has chronic bronchitis, for example, maintains higher than normal hemoglobin levels to increase the body's O2 carrying capacity. It's a compensatory mechanism that we keep in there. That's why people with COPD, they have decreased oxygen levels, so we don't turn their oxygen way up. If we do, we can knock out their normal stimulus to breathe, which is hypoxia, by increasing the oxygen and actually cause death. Clinical reasoning. COPD, no more than 2 liters nasal cannula. Acid-base imbalance. Cells are very sensitive to changes in the pH of body fluids. Acids are continually released as normal waste products of cellular metabolism. So, carbonic acid, what should have you been thinking? Lungs, respiratory acid component. It's eliminated by the lungs. It's expressed as H2CO3, but we cannot express this as an equation in the body, so we measure it as CO2. Bicarb, which is HCO3, bicarb should have been thinking what? Should have been thinking bicarb, kidneys, metabolic, base component. All right, so here's the key to understanding. The pH is a measure of hydrogen ions, hydrogen ion concentration. So don't get that confused with the acid-base components. Let's just look at pH first. pH is a measure of hydrogen ions. So pH equals hydrogen ion concentration. On a scale of 1 to 14, 7 is neutrality. We learned this in chemistry, biology. Normal plasma, though, pH was what? Normal 7.35 to 7.45. Now, if you look at that small, minute range of normal, that's the narrowest, smallest range of normal of all your electrolytes. Should be scaring you to death because it doesn't take much for it to change and it doesn't take much for it to go south. Maintenance of a stable pH of body fluid is essential to life. This is another norm to remember. Normal pH, 7.35 to 7.45. Now, that's arterial blood. Venous blood would be a little bit different. That's why you don't want to accidentally get a venous sample. Venous samples would be more like 7.31 to 7.41. So for test purpose, we're talking about arterial, 7.35 to 7.45. Now, let's think about this. 7.35 to 7.39, we don't think that's a significant change, really. But really, when you think about it, it could be a significant change if you were going to 7.4 to 7.3. A change of 1 pH unit actually represents a 10-fold change in the free hydrogen ion concentration. So really, that's a large increase in hydrogen ion concentration, even though it looks like it's only changed by a 10th. So very, very scary here. We have to really, really watch pHs. The pH measurement of an ABG analysis assesses the overall acid-base balance. The higher the hydrogen ion concentration, that's our acids, they're acids. The higher the acids, the lower the pH. We learned that in chemistry. It's more acidic, therefore it's acidotic. The lower the hydrogen ion concentration, the higher the pH, the more base, the more alkalinic. Then, therefore, we have alkalosis. So if our norm is 7.35 to 7.45, anything below 7.35 has more hydrogen ions, therefore it's more acidic, therefore it's acidotic. Anything above 7.45 has lower hydrogen ion concentration, has a higher pH, therefore is more alkalinic and results in alkalosis. So the pH reflects the regulation of hydrogen ion concentration, and it will tell you if it is acidic or if it's alkaline. So if we want to know if someone's in acidosis or alkalosis, I have to look at the pH. Okay? pH concentration of an acid element in a solution is equal to the hydrogen ions. Okay? Norms. Normal pH, 7.35, 7.45. Have you heard that several times now? Must be very important. Okay, normal pH, CO2, CO2, carbonic acid. What was you thinking? Should have been lungs, respiratory, acid component. Normal is 35 to 45. Normal bicarb, what went through your mind? Should have been kidneys, metabolic, base component. Sorry, I got a really dry throat. I'm trying to take some water. So the two organs which control the acid-base balance are the kidneys and the lungs. When either organ fails, it is impaired, and the balance becomes disrupted. So these are three important norms to remember for the exam, as well as your normal O2 and O2 sat. Sorry. So when the kidneys fail, the resulting imbalance is metabolic. You should have already been thinking metabolic. When the lungs fail, the resulting imbalance is respiratory. Lungs, respiratory. Now, our body has a first line of defense called buffers that try to help us when our pH gets off just a little. And normal arterial pH is maintained through various buffer systems that work within minutes. And a buffer is simply a substance that can either act as a chemical, that acts like a chemical sponge. In other words, it can either soak up or it can release hydrogen ions so that the pH remains stable. Some buffers are present in all body fluids and act immediately within seconds, but react only when there's too much acid or base present. So that's one of the things that you want to consider, that we do have a buffer systems throughout the body that actually help. Some of your main buffer systems, and your Osborne book does not do a good job of discussing this, is your chemical mechanisms. Let me look here. Your chemical mechanisms or chemical buffers that are located in your body would be like your bicarbonate buffers and your phosphate buffers. Okay, these react very rapidly, as well as your protein buffers. Now, your protein buffers would be like your hemoglobin, albumin, your globulins. All of these buffers act readily rapid and provide an immediate response to changing conditions, but they can only handle very small fluctuations in hydrogen ion production or elimination. So unless it's a very minute thing, your chemical buffers are not going to be of much help. Therefore, your main buffer systems are going to have to kick in, and that is your carbonic, bicarbonate buffer system. And you should have been thinking kidneys and lungs. Respiratory mechanism, your lungs would be your carbonic acid portion that's helping. And how do your lungs help when you have acidosis or alkalosis in the kidneys? Well, you either increase your respirations to help blow off some of the acids, or you decrease your respirations to help retain some acid. Renal mechanisms, which come about by the kidneys, help by controlling bicarbonate acid or hydrogen ion excretion. And where does that happen? In the kidneys. So if you're in respiratory acidosis and you have too much acid, then it's going to help by getting rid of some acid in the body or retaining more base. It's going to do the opposite to try to bring that back in to a buffer system and balanced, because we want to keep it all balanced between 7.35 and 7.45. Of these systems, the main buffer system, again, is the lungs and the kidneys, or the carbonic bicarbonate buffer system. Now, there's a ratio that should be kept, and the normal ratio is 20 to 1. That is the normal 20 to 1 ratio of bicarbonate to carbonic acid. So 20 bicarbonates to 1 carbonic acid keeps it in the arterial blood pH normal. Now, if that gets out of balance at all, then you're going to see a seesaw effect happening, okay? The scales are going to tilt. And I posted a picture of some scales. Hopefully you downloaded that. If not, you may want to pause for a minute and go download. Because if you look at the scales, it tells you 1 part carbonic acid from the lungs is equal to 20 parts of bicarbonate from the kidneys to make the scale balanced, so that it stays in the normal area of 7.35 to 7.45. So let's think of this balance kind of like a seesaw too in your head. One end's acid and the other end's base, okay? So looking at this balance here, what would happen if I was to put extra acids on this side? If I was to put where it says 1 part carbonic acid, I was to go and put on the scale a bunch more on that side. Doesn't it make sense it would tilt that side? Like a seesaw, more weight, it would go downward. Therefore, your pH would fall below 7.35 and acidosis would result. Now, if you get below 6.8, you're looking into death can occur. Same thing on the other side. If I was to look at this scale and I was to go and put extra bases on that side, then the scales or the seesaw effect would tilt that way. So now I would go above 7.45 and alkalosis would exist. So again, what happens when pH drops below 7 or rises above 7.8? Rest in peace, death can occur. That's why we want to be clinically reasoning. We want to be looking at those lab values and watching them carefully because there is not much room here for error. All right, what about compensation? Well, first of all, what's the difference between compensation and correction? Compensation, when we think about it, is the effort of the body to maintain normal pH. Okay, that's what we call. And when it doesn't, when pH is not normal, then we start compensating for that. Okay, now compensation's temporarily. You can only breathe so fast or slow your respirations down for so long. So and after a while, your kidneys can only compensate for the respiratory system for so long. So compensation's temporary. But it's when the other body kicks in to try to help maintain the normal pH. Correction, on the other hand, is the process where the system that was not functioning properly becomes repaired and is now working. This is a long-term fix. We've actually corrected the system that was not working, and now we have corrected the acid-base imbalance. So in compensation, the system, which is still functioning properly, is the one that's responsible for returning the pH to a normal range. For example, in respiratory acidosis, oops, which system's not working right? Respiratory, think lungs. The lungs are broke. Oops. So the kidneys, the system that is working properly, has to compensate. How are they going to redo that? Well, if you're in respiratory acidosis, you have too much acid. So either the kidneys are going to have to retain more base, or they're going to have to excrete more acidic urine, more hydrogen ions. They've got to try to get rid of acid because you've got too much in the body right now. When analyzing ABGs to check for compensation, you would initially label any pH below 7.35 as acidosis and any pH above 7.45 as alkalosis. Compensatory mechanisms can only affect a temporary or partial change, so normal pH can only be maintained by curing the cause. So step 1 is always label the pH. So look at your pH, you know the norms. You know if it's below 7.35, it's acidosis. If it's above 7.45, it's alkalosis. Compensatory mechanisms will only affect it temporarily and a partial change. So only way to make that normal pH stay that way is to treat the cause. Correction. So what is the major effect of acidosis on the central nervous system? Depression or stimulation? We've already talked about this. It is depression. Too much acid depresses the central nervous system. The major effect of alkalosis, too much base on the brain, is depression or stimulation. And the answer is stimulation. Now that's going to help you when you think of signs and symptoms. So if you think about someone who's acidotic and it's depressing the central nervous system, then doesn't it make sense? Then you're going to see things like disorientation, confusion, lethargy, possible coma. Now, these aren't written in stone because depending upon the cause, you may see some of these in the other one. The major effect of alkalosis, think stimulation, tetany, muscle twitching, convulsion. And that's important to remember because that will help you with signs and symptoms. Bicarb, base. I was thinking base. I was thinking kidneys. I was thinking metabolic. I hope you were too. Now, your book states the norms a little bit different, and so does your lab book. For test purposes, 22 to 26. 22 to 26. This level is primarily affected by metabolic changes, kidney. Now, this is the base part. Remember, base, base, base. Okay? So if I have an increase in bases, which is 22 to 26 is normal, and I have more base, think about your scales. They're going to go to the base part and become more alkalinic. So greater than 26, that means I went to those scales and I put more base on that side. On the base side, they went down. I'm in metabolic alkalosis. If I went to those scales where the base is, where that 1 to 20 is, and I started taking it off, it would tilt the other way, indicating metabolic acidosis. So this is your base part. Anything above 26 is going to be alkalosis, base. Anything below 22 is going to be acidosis. Think of your scales. Carbonic acid. Should have been thinking what? Lungs, respiratory, acid component. That's why you cannot get this confused with pH. That's measuring hydrogen ions. This is measuring the acid and base component. So the CO2 is the acid half, and the normal range is 35 to 45. So if this is the acid part, and I've got more than 45, acidosis. If I've got less than 35, alkalosis. And think of your scales. Go back and look at your scales. So, thinking about, let me go back to the previous to make sure I didn't skip anything. No, I didn't. This is just an acid-based mnemonic, and it's called Rome. And if it's a respiratory disorder, then your pH and your CO2 are going to be going the opposite direction, regardless if it's alkalosis or acidosis. What it's also telling you is if it's in a metabolic problem, it's going to be equal. Your pH and your CO2 are going to be going the same direction. They'll both be going up if it's alkalosis and both be going down if it's acidosis. So if it's a respiratory problem, the pH and the CO2 are opposite directions. If it is a metabolic, they're equal, going the same direction. So that's just something to kind of help you there. Your book in Osborne also gives you some charts, tables that helps explain that. If it's a little bit confusing, it does do a fairly good job of explaining that. And that is on table 15-2, 15-3, and 15-4. So if you want to look at those, you can. If it makes perfect sense, then I wouldn't look at it. The kidneys react, the respiratory system reacts to changes in the kidneys within minutes. So let's think about this. It doesn't take long to either speed up or slow down your respirations. So it says the respiratory system reacts to changes in the kidneys. So the kidneys have goofed up and are not working right. That means the system that's working right, the respiratory system, has to kick in there and do something. Remember what we said the respiratory system can do. Hypo or hyperventilations, either blow off more CO2 or retain more CO2. So here's how it works. If you have someone who's in metabolic acidosis, the kidneys are broke and they have too much acid, then the lungs are going to help out by compensating. And how are they going to compensating? By causing hyperventilations. Why hyperventilations? You want to blow off more of that CO2. CO2 is your acid. If you blow off more of that acid, then you're getting rid of that acid and bringing it back into homeostasis or balance. If metabolic alkalosis occurs, now I've got too much base, the lungs are going to have to compensate by hypoventilating. Now I want to retain more of that acid. I have to go the opposite direction. Now, this corrects an imbalance 50 to 70% of the time, but not always. A lot of times you have to go back and actually treat the cause, what's causing this. So after a while, this temporary thing is going to give up. So you want to always go back and look at what caused your imbalance and treat it. Now the kidneys, on the other hand, are a little slower to help out the lungs. So if they get in trouble, it takes them hours to days. We just can't go in there and sit on the pot and say, "Whoo, come on, hydrogen on, excrete, excrete, excrete. I'm going to retain some bicarb and go to the bathroom." It hits you when it hits you. So if respiratory acidosis occurs, the kidneys will compensate. And if you're in acidosis, I need to get rid of acid. So now I'm either going to secrete hydrogen ions or retain more bicarb. Okay? If respiratory alkalosis occurs, now I've got too much base, the kidneys are compensating by either conserving more hydrogen ions, acids, or excreting more base. You have to do the opposite to bring it back into balance. So what are the four main imbalances that can occur? Metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. These are the four major imbalances, and you need to remember these. These are not diseases. These are secondary to disease processes. Let's look at metabolic acidosis. Again, not a disease, a condition caused by a disease or a pathological process. Think of the seesaw, the pairs of scales. In order for metabolic acidosis, in order for acidosis to occur, what has to happen? Either I've got to put more on the acid side and make it tilt this way, or I've got to take some off the base side. That's the only way. So what can cause an increase in acids? Diabetic ketoacidosis, DKA. If glucose is unavailable for energy, the body uses fats. When you break down fats, they become ketones. Ketones are acids. Poisonings. For example, aspirin, alcohol. You break it down, it's acidic. Lactic acidosis. This is a result of anaerobic glycogenolysis. For example, cardiac arrest. When you go into cardiac arrest, you build up lactic acid because of tissue hypoxia. Therefore, you end up with more acids. Renal failure, also known as uremia. That's the end byproducts of protein metabolism. If they're not being excreted, they're being built up. You're not excreting the hydrogen ions, the acids, the end products of protein metabolism. Therefore, you're building it up. So all of these conditions could potentially cause an increase in acids. Now, what could cause a decrease in base? Diarrhea. Okay? And that's because you've got to think about the pH of what's going on before you start. Your pH is normally in the intestines. It is normally alkaline. So if you get rid of that, then you have to worry about going the opposite direction, acidosis. Pancreatic drainage, same way. Primarily starting out alkaline. You start losing a lot, then you're losing your bases, so you're going to increase your acid. So you're going to tilt the scales that way, and you're going to become acidotic. Drugs, some of your medications can induce this, as well as what's called renal tubular acidosis. Renal tubular cells are unable to reabsorb bicarb, so therefore you lose bases when you have renal tubular acidosis. So if you think about these things in that scale, it helps keep all this in track. Signs and symptoms of metabolic acidosis would be things like lethargy, Kussmaul's breathing, hypotension, clammy, a general depression of the central nervous system. Okay? A general depression of the central nervous system. When we think about other things and the way that it affects each system in general, when we think about the key features of acidosis, Let's think about the cardiovascular. Cardiovascular, you could see particularly changes in the electrical conduction. And that would be things like tall T waves, widened QRS, prolonged PRs. So I know we've not went over that, so I'm not going to get into that very deep. Just know delayed electrical conduction. Central nervous system, we've already talked about that. This is acidosis, so think about depressed activities, lethargy, confusion, stupor, coma. Neuromuscular, hyporeflexia. Things are slowing down here. Hyporeflexia. Can have some weakness, flaccid. Respiratory. Kushmal's respirations. That's those slow, deep respirations in an attempt to blow it off. And that's what the lungs do. So Kushmal's respirations are normal with someone who's in metabolic acidosis. And the skin. The skin can be warm, flushed, and dry. It can also progress to cyanotic if you let it go. Okay? And I say dry, really it's kind of clammy to dry, depending upon what's going on. All right, what's the treatment then for metabolic acidosis? And the treatment is treat the cause. For example, if the cause is diabetic ketoacidosis, and I have posted a handout with all the common causes of the 4 major imbalances, know it, know it, know it. For example, if the cause is diabetic ketoacidosis for metabolic acidosis, remember those causes, that was one of them, then you're going to have to treat the DKA. And once you treat the DKA, the signs and symptoms of metabolic acidosis will reverse. So here's another little thing on metabolic acidosis. Changes in the level of consciousness, the Kushmal's respirations. It gives you some common causes here. Decreased ability of the kidneys to excrete and conserve base. And again, you can have warm flesh skin, nausea, vomiting, and diarrhea, twitching, decreased blood pressure, and headache. And you may see some of these same signs and symptoms depending upon what system it's affecting, whether it's alkalosis and acidosis. So one's down. Number 2, metabolic alkalosis, just the opposite. Think of the scales. So now either I've got to increase the bases on the side of the bases to tilt the scales to alkalosis, or I've got to decrease the acids. The only way that's going to happen. So what's some common causes? Well, common causes for increase in base would be administration of excessive bicarb. Maybe someone's taking too many Tums, baking soda, Alka-Seltzers, as my grandma would call them, and take them excessively. And she had symptoms of metabolic alkalosis quite a bit. Decrease in acids. Increased loss of hydrogen ions and chloride through vomiting, nasal gastric suctioning. Well, how can that happen? Just the opposite of what you're thinking. If someone's vomiting, they're getting rid, remember the normal pH in the stomach's acidic. So I'm getting rid of that. I'm decreasing those acids. So I'm going to lean towards metabolic alkalosis as a result of that. So you always have to think about the pH of that environment that you started with and what it's going to result in. Increased loss of hydrogen ions, potassium, and chloride through diuretics, Cushing's syndrome. Some of those things could also decrease the acids. So signs and symptoms would be central nervous system stimulation. Because now, remember we said it stimulates. So now we're talking about anxiety, irritability, positive trousseaux, and Chauvistic's sign, which we'll talk about here in just a little bit. And paresthesis, tingling. Okay. You also may see some increase in respirations, nausea, vomiting, and headache. But now you would see hyperreflexia instead of hyporeflexia, and more of your muscle cramping, muscle twitching now. So even though we may see some of the signs and symptoms, we're definitely going to see different ones as well. So these are the ones you're going to see in general. Treatment of metabolic alkalosis, treat the cause. For example, if it's vomiting, help them quit vomiting. Metabolic alkalosis, again, just going over some of the signs and symptoms. You can look at them there. Okay. Now, this does say you may see some confusion with this. You may, because after a while, they may give up. They may become so restless and at starting out restlessness, but after a while, if you don't fix it, they're going to become lethargic and confused. So even though they will start out with that stimulation, anxiety, irritability, then you may see a depression if you don't correct it. Respiratory alkalosis. The main cause is hyperventilation. Respiratory alkalosis, hyperventilation. So I'm blowing off too much CO2. Hyperventilation, what causes that? Several things. Can be something that results in hypoxia from like a PE, severe exercise, shock, anything that causes a restriction of the diaphragm. Certain medications, mechanical ventilation, certain central nervous system diseases, as well as fear, pain, anxiety, and fear. And correction of metabolic acidosis overcorrection can cause this. Signs and symptoms would be the same as what we talked about earlier. Rapid breathing, tingling, dizziness, lightheadedness, and everything else that we talked about with alkalosis on the other slide. Treatment, treat the cause. If it's because they're very anxious, have them breathe into a bag so they're rebreathing CO2. If it's too much anxiety, you may have to have sedation. But the big thing with all of these is treat the cause. So respiratory alkalosis, and you can read over that. Respiratory acidosis. The main cause is just the opposite, hypoventilation. Now I'm retaining too much of the acid part, CO2. Hypoventilation causes could be lung diseases such as COPD, asthma, and CF. So I have someone who comes in with COPD, I should always be thinking respiratory acidosis, respiratory acidosis. Same as with asthma and cystic fibrosis. Anything that causes limitations to the chest wall and diaphragm, rib fractures, severe obesity, pregnancy. Someone's severe obese, they're at risk for respiratory acidosis. Someone who's pregnant is at risk for respiratory acidosis. Clinical reasoning. Central nervous system depression, brain injury, drug overdose, anesthesia, carbon monoxide poisoning. All of these are depressing the central nervous system. And overcorrection of metabolic alkalosis. Signs and symptoms of respiratory acidosis would be confusion, increased heart rate, headache, diaphoresis, lethargy, depression. Anything, think about depression of the central nervous system. And we talked about some of the acidosis earlier. You could still see some of those delayed electrical conduction on the cardiovascular system. Now think lethargy, confusion, stupor, hyporeflexia. Okay. Treatment, treat the cause. Could be intermittent positive pressure breathing. Could be bronchial dilators to open it up so they can breathe better. Could be progesterone. It's a respiratory stimulant for obese patients to breathe. Could be that they don't need as much narcotics. Be very careful with someone who's in respiratory acidosis giving them narcotics or sedatives. It may make the acidosis worse and actually lead to death. There's a mnemonic, a little picture. If you need to look at the picture. So putting it all together, this is what you've got to know. So before the test starts, I would show my piece of paper and I would write all of these down and I would know that this is right off the bat so that I don't get confused, because once you start interpreting all these ABGs, you may get confused. So I would write this down. pH, normal, 7.35 to 7.45. Greater than 7.45, alkalosis. Less than 7.35, acidosis. Remember, this is my pH. I'm measuring hydrogen ion concentration, which are acids. Bicarb, I'm thinking kidneys, metabolic, base. Normals 22 to 26. This is the base part, so anything over 26 is alkalosis. Anything less than 22 is acidosis. Think of your scales. CO2, normal 35 to 45. Anything less than 35, this is my acid part, is alkalosis. Greater than 45, my acid part, so it would be acidic. Know this, know this, know this. So what am I doing with acidosis, alkalosis? With alkalosis, I'm kicking the pH up, so your pH goes up. With acidosis, I'm sliding down the scale, so the pH goes down. Okay, and it says 4.4, but it's 7.35, 7.45. Can a patient have mixed acid-base imbalances? Absolutely. Think about a COPD patient. Respiratory acidosis, that should have just clicked. But think about the COPD patient who's on diuretics or steroids or taking too many Tums. They could also have a metabolic problem. So yes, you can see mixed. FYI, it's usually an electrolyte imbalance that will coexist with your acid-base imbalance, particularly potassium. Hyperkalemia is common with acidosis and hypokalemia with alkalosis. You need to remember that. Hyperkalemia is common with acidosis. Hypokalemia is common with alkalosis. Okay? And if you don't understand why or you want more information on that, I'll be happy to get that to you, and that explains it pretty well. Okay? Nursing diagnoses: ineffective breathing pattern, impaired gas exchange, sensory perceptual alteration due to the tingling, tissue perfusion can be altered, anxiety, fatigue, and risk for injury. Now, there are others. Decreased fluid volume deficit, decreased cardiac output. We could go on and on and on. But the nurse can optimize respiratory and renal function. And that's very important that we do that. That we know just by going in and positioning someone, we could actually potentially keep them from going into acidosis or alkalosis. By doing good pulmonary hygiene, good suctioning, good coughing, we can help prevent an acid-base imbalance. By keeping someone hydrated, by decreasing their anxiety, by watching their drug medications, by administering oxygen therapy as ordered and knowing what the norms are. So you have a very, very important role. Air bubbles. What can be sources of errors if you do draw on ABG content? Air bubbles can increase O2 levels, decrease CO2 levels, and increase pH levels. Venous samples. If you get a venous sample, it can cause abnormal values. Anticoagulant effects decrease pH. And if they have fever, that can affect the overall O2 level. Okay? So these are all major sources of errors that can occur in ABG samples. Okay? So now we're ready for interpretations. There are 3 steps. After you look at these 3 steps, I want you to go in and read your article, Turning ABGs into Child's Play. This article is so simple, anyone can read it and anyone can do it. Okay? So I want you to work through every single one of the scenarios, and then I want you to get back with me on what you don't understand. Okay? There's 3 steps. You want to label the pH. You want to find the cause. You want to check for compensation. Okay? So the first thing you're going to do is label the pH. How do we know how to label the pH? We talked about that earlier. We simply look at the pH. Is it acidosis or is it alkalosis? Anything above 7.45 is alkalosis. Below 7.35, acidosis. So the first step is always label your pH. The second step is find the cause. Well, it can only have one of 2 causes. Either it's metabolic, and I don't know about you, but I was thinking bicarb kidneys, or it is respiratory, and I'm thinking CO2 in lungs. So if something's wrong with the bicarb, it's metabolic. If something's wrong with the carbonic acid, CO2, then it's respiratory. The third step, though, is check for compensation. Compensation can be one of 3 things. You can have complete compensation, partial compensation, or no compensation. And your book, that article actually does an excellent job of also explaining the types of compensation. Now, I have a little pen that I have gotten that I can record into and do some other things, and I'm hoping to get that all together for you so that I can post some examples and work through this step by step and show you what I mean by labeling the pH, finding the cause, and checking for compensation. So hopefully that will be coming soon. That's something new that I'm going to try, and y'all can let me know how that works, okay? So think of those 3 steps. All right, so I want you to, what we're going to be doing when you read that article, we're going to be playing some tic-tac-toe 3 in a row. Your article will tell you to make you a grid. You will make a grid. Once you make your grid, and it shows you that in your article on page 38, acid, normal, and alkaline. This tic-tac-toe, once you fill in the grid 3 in a row and you count the top one as 1. So if you put 2 more things under acid, that's 3 in a row, and you're ready to diagnose your patients once you have 3 things in a row. Okay? So tic-tac-toe, an overview of the article. You have to know the norms of pH, CO2, and bicarb in order to interpret any ABGs. So write that down. Set up your grid like page 38 of your article. Put acid, normal, and alkaline across the top. Okay? Once you do that, then you simply fill in the answers. Okay? So let's just do one of these together so that you feel a little bit more comfortable. Okay? Now, I did say that you have, whoops, let me go back, sorry. Back. 3 types of compensation, okay? And I'll talk about that a little bit when we go through here. So let's look at page 38 of your article, and it talks about a Robert Miller, okay? He's a 70-year-old diabetic who has a long history of not taking his insulin. I don't know about you, but I'm already thinking DKA. I'm already thinking metabolic acidosis before I even start this. He's just been admitted to your unit, and you receive the following ABGs: pH 7.26, CO2 42, and bicarb 17. You plug your 3 parameters into your grid. So the column that tells you the pH is where you would plug the pH, okay? So on this one, if we look at the grid, the pH was 7.26, so it goes under acid because that's acidosis. The CO2 is 42, which is normal, 35 to 45, so it goes in the normal column. And the bicarb is 17. That's your base, and you don't have very much of it, so you go in the acid part. So I have 3 in a row. I'm ready to diagnose my patient. I'm in the acid part, so I'm acidosis. Oops, I see bicarb, and if I know bicarb, it's kidneys metabolic, so I know I am in metabolic acidosis. And that's what we expected for this patient. The third step is to determine compensation. If it falls in the normal column, if either the CO2 or the bicarb, either one is in the normal column, it's not doing anything to help the system not working. Therefore, it is no compensation. So in this case, Mr. Miller has metabolic acidosis with no compensation because the lungs are normal. They ain't done anything. The only way to have partial compensation would be if that CO2 would have been in the alkaline. They have to be opposite each other, okay? All right, so let's now go to, because the next one's a normal one as well. So let's go to page 39 of your article, and I want y'all to sit down and really read this article. And let's go to Miss Silver, okay? Oh, I'm sorry. No, we've already done Miss Silver. Let's look at Lewis. Lewis is a 64-year-old patient who has a long history of COPD. Uh-oh, I'm already thinking respiratory acidosis because I know my causes. I've learned that handout. He presents today with a slight fever and complains of shortness of breath and coughing up green-colored sputum. His ABGs are 7.26. Oops, that's acidosis, goes in the acid column. CO2, 52. Normal is 35 to 45. That's too much acid, goes in the acid column. Bicarb, 22 to 26. Oops, I've got a lot more base. That goes under alkaline. Now, we know we've got 3 in a row. We're ready to diagnose our patient. So in this case, I know it's acidosis. It's respiratory because it's CO2. So respiratory acidosis. The third step's compensation. Well, neither one of them's in the normal column, so it's not that. But if you look, your HCO3 is opposite your CO2. So if they are opposite, it's partial compensation. That means that other system's kicking in temporarily trying to help. But if you remember, the only way to truly help is to treat the cause. Now, there is one screwy thing that can happen to you. You can start out with a normal pH. If you start out with a normal pH, you have to do 2 steps. You have to label a pH 1 and a pH 2. So let's look at page 39 in the middle, Greta. Greta is 45 and she has myasthenia gravis for 5 years. She was recently admitted and complains of increased dyspnea, shortness of breath, even at rest. Her ABGs are pH 7.36. Uh-oh, that's normal. So what am I going to do if I have a normal pH? Anytime you start with a normal pH, you don't even have to do compensation. It's already complete. Because remember the hokey pokey, what it's all about? Maintaining a normal pH. I'm sorry. So, if you have a normal pH, you have completely compensated. You have corrected it. So her ABGs are 7.36. So what do I do with that? Well, if 7.35 to 7.45 is normal, what's right dab in the middle? 7.4. If 7.4 is right dab in the middle, then when you have a normal pH, you've got to break that right down the middle. Anything below 7.4 then becomes acidosis, and anything above 7.4 becomes alkalosis. So you have to do a pH 1 and a pH 2. Be sure to read this article. It explains it well. So it's below 7.4, the middle of 7.35, 7.45, so that's acidosis. So my pH 1 went in my normal column, but my pH 2 went under acidosis because I want to find out what my original cause was, even though I have complete compensation. So if I look at my CO2, it's 50. That's acid, so my CO2 goes under my acid column. My bicarb was 34. That goes in my alkaline column because it's too much base. So now I'm ready to diagnose my patient. My patient has acidosis. We know it's respiratory acidosis, and we know that it's complete compensation because she has a normal pH now. Okay? So compensation, you only have one of 3 things. If your CO2 or your bicarb falls in the normal column, either one of them have a normal value, you have no compensation. If they are opposite each other with an abnormal pH, you have partial compensation. If you start with a normal pH, you have complete, and you have to go ahead and do the grid and do the pH 1 and the pH 2. Again, I don't mind going over this one-on-one with anyone who does not understand it, but make sure you read your materials and read the articles first. And if you still don't understand it, please don't hesitate to get with me. All right, you have some ABG interpretations to do at the end of the PowerPoint. If you'll email your answers, I'll let you know if you've interpreted them correctly. After reviewing the material, you still need help, I am available. All you have to do is ask. Okay? So once you have 3 in a row with tic-tac-toe, make sure that you're ready to diagnose. Label your pH step 1. Determine the cause step 2, metabolic or respiratory. Step 3, compensation. All right, practice makes perfect. So work together, interpret the results, and tell what type of compensation. So make your grid real quick. Okay, if I was to make my grid real quick, I would put normal in the middle, acid in the front, and alkaline in the back. pH 7.23. I know that's acid. I'm going to put it under the acid column. CO2 is 60. Normal's 35 to 45. This is my acid component, so I know it's going in the acid part, CO2. Bicarb normal is 22 to 26, so that fell in the normal. I have 3 in a row. I'm ready to diagnose my patient. Step 1, label my pH. I'm in the acidotic, so I'm acidosis. It's CO2. Remember, that's why I hammered that in your head. Think CO2, think respiratory, think lungs, think acid. So now I know it's respiratory acidosis. Step 3 is compensation. One of them's in the normal column, so I have no compensation, none. Okay? I want you to practice 1 through 5. I want you to send them to me in an email, and I'll be getting back with you to let you know if you're on the right track. Thank you.